Okay, great. So without further ado, I'll introduce our speaker, who we're very pleased to have here with us today. Mr. Ashraf is a great friend and mentor of mine, who I was lucky enough to meet when I was at Guy's and St Thomas's when he was working there. He's a graduate from Imperial Medical School, a great medical school, and is now an ST2 trainee in cardiothoracic surgery. He's worked in some great places such as the Brompton and Guy's and Tommy's, as mentioned earlier, and I'm sure we'll all be very inspired by his talk that he's going to give us here today. So without further ado, over to you, Mr. Ashraf.
Thank you very much, Laura, for that lovely introduction, and hello everyone. Thank you so much for those of you who've tuned in, and to the NSTS for inviting me to speak tonight. I hope to give you a bit of an insight into cardiothoracic surgery over the next hour or so. When I was thinking about what to put in this presentation, I realized that there's such a large scope for what we can put in here. In cardiothoracic surgery, some operations can be so complex and literally involves stopping your heart for an hour or so, and the physiological impacts of that on a person can be rather unique. That's why there's even a specific subspecialization, even in intensive care, for the critical management of cardiothoracic patients, which currently, by the way, it just happens so that that's where I'm currently placed, working in the ICU at the Brompton. And that in and of itself is so fascinating, and it's fine art. So for this presentation, I decided that the primary aim would be to simply give you a flavor of what the specialty actually entails, and hopefully to teach you a little bit about some of the key pathologies and procedures that you can encounter within the specialty, as I feel that this is something that's sometimes rather skimmed over in medical school. At least in Imperial College, it certainly was. You learn an awful lot about cardiology and respiratory medicine, but the surgical aspects of the specialty are often sadly left out, or as I said, they're just skimmed over. Apart from obviously when you're expected to hear the click of a metallic heart valve replacement, and then spot the cheeky yellow warfarin booklet and tucked away, hidden on the seat in the corner in your OSCEs. Yeah, other than that, you don't really get much interaction unless you're lucky enough to just be placed in one of the cardiothoracic centres. But there aren't that many across the hospitals compared to other specialties. So I've tried to make it a little bit interactive as well in part. So please do use the chat. I think there's a poll that was set up to allow you to put responses to some of the questions that will come up. I know it's late in the evening, but don't worry, it's multi-choice responses, so you won't have to think too hard. Okay, so an overview of what I'm going to be talking about today. I'll briefly do a quick introduction to the specialty and just a little bit more about the specialty as a whole. Then I'll go on to talk a little bit about some of the key cardiac pathologies and key thoracic pathologies that you can encounter, and some of the surgical procedures that we do, as well as some of the things that I think may be useful to you, even as sort of foundation year doctors going on to on the wards, or if you're on call on a surgical job. And then I'll finish by talking briefly about how you can get involved and just get a bit more, learn a bit more about cardiothoracic surgery beyond this talk. Right, so an introduction to the specialty. So in a nutshell, and I say this in a completely unbiased tone, it is by far and away the best surgical specialty that there is. And I mean, I don't mean to brag on the specialty's behalf, but what other specialty grabs the attention of the adored princess, no less? There's a reason why she was called the Queen of Hearts. But in all seriousness, you are dealing with two of the most vital organs of the body in cardiothoracic surgery, your ABC and your A to E. The work that you do, therefore, is extremely gratifying, and I mean, it can be very challenging at times, but the operations are often life-changing in what you do. And as I said, they can be very, very challenging. So it's not something that's for everyone. As you can see from just from the image alone over here, you got some very, very major structures, and to be operating in the midst of a beating structure with such major arteries and structures coming out of it, and vessels and nerves and all sorts, you've got to show immense courage in order to be able to, actually go into that. And therefore it's not always one, I wouldn't say it's one for the faint-hearted, so to speak. I thought I'd talk a little bit about dispelling some of the myths that there are about the specialty. One of those which I was guilty of falling into and going through medical school, especially towards the end when I was sure I wanted to do surgery, was that I thought, having graduated, that you have to have geared your application towards it since, the day you were born. But I feel that so long as you have the drive, the passion and determination, there's no reason why you cannot build a competitive portfolio geared towards cardiothoracic surgery in a year or two. And it's more about just taking that jump and actually, experiencing it a little bit, and to help you make that decision as to whether you want to do it or not. Myself, for example, 2 years before applying, I hadn't even sort of had very little to no exposure to specialty myself, and I managed to be successful in applying for it, and now I'm a cardiothoracic trainee and absolutely loving it. So there is nothing that should really stop you from at least giving it a go and applying. There's other cases of that. I've got this year, I was mentoring some ST1 applicants, two of which wanted to actually do, one of them wanted to do plastic surgery, the other neurosurgery. So they'd been gearing all their applications towards that. They did a job in cardiothoracic surgery, one as an F2, one as a CT1, and that just changed their mind completely. And in that year, they managed to, do what they needed to do to try to get the experience they needed in cardiothoracic surgery and build a competitive application. I also had this perception that cardiothoracic surgery was only for a special niche of people, and that it only really attracted a certain type of character. But having worked in the specialty for a few years now, I can confirm that this simply is not the case. I've met some of the most talented and inspirational surgeons and trainees who are also great people too. Yes, like in most specialties, it can be quite demanding, but there's still absolutely no reason why you cannot have a life and go out and enjoy what you want to do too. We'll get into this a bit later as well, but thoracic surgery can also be a bit more sort of catering towards a more flexible lifestyle. And in general, compared to cardiac surgery, you don't have to come in so much overnight. Rarely, if ever, actually, in my experience, having done both cardiac and thoracic surgery. Some things you should be aware of. The operations can be very, very long. I've stood in, 10-hour operations, and they can be even longer than that. And that's not for everyone, and understandably, but some people enjoy the challenge of that. And there's a saying in surgery, and in terms of what we call this, and we usually refer to it as a character building experience or character building operation. So you do come across those from time to time. They're not all so long, but they're due to the challenges in some of these operations, they can drag on, especially in something like an aortic dissection, which can take a long time to sort out in the end, but sometimes it can equally be, 3 to 4 hour operation. So for that reason, I've got this picture of a pair of clogs up there. So long as you've invested in a good pair of clogs, and you've got a good strong core, and you've worked on your back muscles, you should be in good shape to take you through these long operations. And funny thing happened to me, actually, in terms of the importance of clogs. Funny thing happened to me in my recent placement I had in Harefield, and I'd lost my old clogs I'd been using, which were really, really good. And usually that means that you're stuck with getting or having to use not the disposable, but the ones that are just given out willy-nilly by theatre staff, which are never as good as the ones that you purchase. So rather than doing that, I'd always see if there wasn't a surgeon about and just take one of the ones that weren't being used but belonged, I guess, ultimately to someone else, and because they're often just left lying around. And one day, there was a pair of clogs that caught my eye, and they were just this really unique color, and like a child with having found a new toy. I was just like, wow, these look really cool. Try them on. They were the most comfortable like shoes I'd ever put on. So every time they were available, I'd put those on and wear them. One day I'd put them on and I was in theatre 4 or something, and I'm just sat there waiting for the patient to be anaesthetized. Next thing I know, I get a tap on my shoulder and I turn around and I see this figure behind me, and I'm a bit bemused, like, who is this? And he goes, "Excuse me, my friend, may I have my shoes back, please?" And to my horror, it was one of the consultant cardiac surgeons at the trust, who I hadn't actually been able to meet at the time, but he was so friendly and nice about it. He obviously gave me back his crappy disposable clogs, and I gave him his back, and was left a bit red-faced. But after that, it was all fun and smiles, and that goes back to me saying how you get friendly characters in the specialty. They're not, and they're a really fun bunch as well. I've already mentioned how you can have a lot of on-calls. These patients by nature are very critically ill, usually after, or they require a lot of, they've been through a lot of, they've had a lot of trauma inflicted on them after an operation. So the immediate post-op period can be extremely sort of nerve-wracking in the sense that, are they going to do, or is there something that I'm going to have to come in for? But usually with the good surgeons I've worked with, this is not often the case. So every step is taken, every precaution is taken to make sure that things don't happen in such a way that you do have to come in. And that's part of the challenge of the specialty, to make sure that you are extremely precise in everything that you do, and the patient's life depends on that. Ultimately, though, it is really a thing of beauty, the specialty. And I remember my first day when I went into a cardiac surgery theatre in particular, and it really was a sight to behold. The operation. I was absolutely awestruck from the moment I stepped in and saw the stenotomy and the steps occurring, and this beating heart in front of you, keeping the patient alive, and how it was manipulated and so precisely operated on. It was something that really struck me, and I don't think there is a more beautiful specialty in terms of the cleanness and precision of the operating. And you really do make an instant and profound impact on the patient's life. People often come in barely able to take a step without becoming short of breath or having chest pain, or they've got a cancer that's going to spread and end their life very soon if you don't do anything about it. And it really is truly a gift to be able to help them in this way. There is a lot of scope for academic work as well, and the specialty is evolving rapidly, in fact, right now. So there's a lot going on, and a lot that you can get involved with in that regard too. For those of you that enjoy physiology, there is a lot of it, and that's something I'm experiencing now, as I mentioned earlier. There's a lot of, it's very intricate the way that, and very unique the way that a cardiothoracic patient recovers after an operation, because you've literally stopped their heart for however long, and that in itself has a lot of implications in terms of their recovery, and it's very interesting. I always found physiology very interesting, so that's great. Right, so I'm going to talk a little bit about some of the cardiac pathologies that you can, the common ones that you can come across. So mainly I'll be talking about coronary artery disease, valvular disease, and the emergencies I was talking about, which is usually, more often than not, an aortic dissection, although there are others. And maybe I'll talk a bit about tamponade and a few other things as well. So coronary artery disease, as you can imagine, cardiac surgery forms the bulk of the work. By definition, it's the narrowing and thickening of the arteries caused by thickening and loss of elasticity of the arterial wall, a process called atherosclerosis. often these patients are initially treated with medical therapy, and if they're able to, obviously with the introduction of stenting many years ago now, that is usually the first line. But there is essentially a set of criteria that by the AHA and ACC, which are governing bodies in America, which stipulate the cases in which a CABG or surgery would be a better form of management for these patients. So before going on to that, I thought it'd be quite nice at this point to help everyone get a bit more engaged, to run through very briefly the anatomy of the coronary arteries. So we'll start to kick things off. It's a relatively simple question, hopefully, on which vessel is the circumflex artery here? I think one of the panel is going to help out. Okay, here we go. I can see the poll. So I'll give you a few moments to respond. I don't know if everyone else can see what the results on the poll are and if that influences people's answers, but okay, I think that's plenty of time. Most people got it right, actually. Yes, it is D, which is the correct answer. This vessel running back along here is the circumflex artery. Just moving on to the next slide. So just in a nutshell, you have two main arteries coming, or coronary vessels coming off the aorta to supply the heart. On the left side, you have the left coronary artery, which is coming off over here, and it comes off and gives you the left main stem. This branches off into two main vessels. So as we've already mentioned, the circumflex runs along back here, and it supplies the outer side and the back of the heart. This vessel over here is probably the most important coronary artery in your body, and it is the left anterior descending, the LAD. That essentially supplies the front of the heart on the left side, the left ventricle, and also the septal areas as well. Then you have the right coronary artery, and that supplies the right ventricle over here. And also you have this right atrial branch coming off here as well. And it gives off other branches, including the posterior descending artery, the PDA, and that's often grafted, and the right marginal artery as well over here. So between the left and the right side, another important thing to mention in terms of the importance of the right coronary artery is that it supplies not only the right atrium, but also the SA node and the AV nodes. So it's fundamental in terms of the conduction pathway of the heart. So if you leave that for too long blocked and stenosed, then it's going to have major implications too. So between the left and the right side, together they can supply the septum of the heart. And a few other structures as well, obviously the aorta running back down here. I'm so glad no one put A as an answer in the previous question. And then you have the superior vena cava and the inferior vena cava, which isn't in the picture, but that would be there. And your pulmonary arteries coming along, pulmonary veins coming off over here, and the pulmonary artery coming out of the right ventricle over here. Right, so as I started talking about before, there are guidelines to determine which patients should be given offered coronary artery bypass surgery. I'm not going to go into those in too much depth, but essentially there's a number of criteria: significant triple vessel disease, significant stenosis of the left main stem, concomitant valvular disease with severe coronary artery disease, and various other criteria. But there is a classification that's been created to help make this decision. And usually what happens is that it's discussed with the cardiologists as well in a joint cardiac meeting referred to as the JCC. Usually what you will have done by then is done thorough history and examination of the patient to find out, you know, what symptoms they're having, as that can play a significant role in whether we and how we manage them. They'll obviously have a coronary angiography done to pinpoint where the degree of stenoses in the vessels and whether how many there are. Echoes are also performed to find out, and this can help decipher the actual whether there's any regional wall defects, motion defects, and whether there is any already ischemic tissue in the heart, in which case there wouldn't be any point in refusing that vessel if it's already dead. In difficult cases where you can't really determine whether or not there is complete ischemia of the tissue, myocardial perfusion studies can be performed. And usually before an operation, carotid Doppler is done to see if there is any, and that's important in terms of when a patient's put under anesthetic, if they've got very clogged up carotid vessels and they'll have reduced blood supply going to the brain, that can have negative implications and become contraindication for major surgery. So now I thought I'd talk a little bit about the actual operation itself. And just to give you a flavor, I didn't really, whilst you hear about cabbages, normally you're just like, okay, what is this? We all know about looking out for the scar on the leg to look for the saphenous vein graft, but it's not always clear what exactly it involves beyond that. So yes, a cabbage, essentially, you're using a conduit to bypass a lesion in one of those coronary vessels. So I'll talk a little bit about some of the conduits that you can use. The most commonly used one is your long saphenous vein, and it's still used to this day, though the technique has evolved. When I was working at Tommy's, I was an amazing procedure that I was lucky enough to do, starting off as a surgical trainee, was an open saphenous vein graft, where, you know, you're performing all the basic skills of surgery you're performing in that procedure, and whatever specialty you want to go into, that is such a useful it's almost an individual operation in itself to harvest the long saphenous vein in that way, because you're using your dissecting skills, your knot tying skills, because it has very delicate branches that come off, and essentially what you take out is going to be ending up on the heart. So there's a lot of responsibility to produce a good vein, and the feist and the angst of some of the surgeons, the consultants at the top, when they receive a bad vein, shows that, and you really don't want to disappoint them. So it's a lot of fun, and you learn so much from doing it. Now it's evolved so that it includes a new technique has evolved to include endoscopic saphenous vein harvesting, which was something that they were doing at Harefield whilst I was there. And this saves you from having a massive incision all the way along the leg to just having two small incisions, one where you enter with your camera and instruments, and one where you come out and tie off the vessel over there. So it does have a significant impact in terms of the cosmetic result, and reduced risk of post-operative infection of the wounds. But it's a completely different skill set, and you may miss out on some of the skills you may gain from open saphenous vein harvests. These other pictures show the other conduits that are commonly used. So another very commonly used one is the left internal mammary artery. So this is often taken down from just behind the chest wall, and it's located just lateral to the sternum. So actually, for example, when you're performing a stenotomy and you're cutting the sternum open with a saw, if you're not careful and you veer off, you might actually go into that vessel, and that would be an absolute catastrophe if you were thinking of taking it down for your cabbage. But essentially, you lift part of the chest up, and again, it's a very delicate procedure because you don't want to damage that at all. This is going to be your conduit for life, hopefully, in terms of providing perfusion to that part of the heart that isn't receiving it. And that's the key with all cardiac surgery, by the way. These procedures you're trying to do something that they're going to, you're doing something they're going to have for the rest of their life. Not always if they're young, but that's what you aim for, is something that will last decades and not just break down in the next 5 years, say. So Lima to LAD is a very common graft that's used. The other less commonly used graft is this, which is the radial artery. Again, it can be harvested open, and there are endoscopic methods which are being used as well. So at this point, I thought I'd ask another question. We just referred to the internal mammary artery. So do any of you know which vessel the internal mammary artery actually originates from? Option A is the external mammary. Option B is the internal intercostal artery. Option C is the aortic, and D, subclavian. Remember, I've given you a bit of a clue in that it passes behind the chest and just lateral to the sternum and travels all the way down. Okay. Slightly mixed responses, but the majority of people got the correct answer there, which is the subclavian. Yeah, so the aorta will give off your subclavian, or brachiocephalic artery, which will then give off the subclavian. And then subclavian, as you can see from this picture, will give off the internal mammary artery, which then travels all the way down. If you can imagine the sternum ends of a hair, so just lateral to the sternum, you have the internal mammary artery passing behind it, and you have to, really delicately pull down the pleura and dissect. You'll have branches coming off of it. As you can see, it gives off intercostal branches. You have to either clip those off or coagulate, use your coagulation to coagulate them off. And then it goes all the way down, becoming the superior epigastric artery. And then you'll tie it off up here and down, not up there, actually, that would be disastrous if you did that, down here, and you cut it down and lay it onto, or anastomize it onto the LAD, usually, on the left side. Okay. So this is a nice picture demonstrating what it looks like in the end. So if the internal mammary artery is used, it comes off the subclavian, and then you only have to make one anastomosis onto the coronary vessels. If you use a vein graft or radial graft, artery graft, for example, you have to end up attaching it onto the aorta. So you have both a distal anastomosis onto the coronary vessel and a proximal anastomosis onto the aorta. And now, this is very, very difficult in practice. And we use loops in order to do this, which magnify everything by 2.5 to 3.5 times. And some of these coronary vessels, if you can imagine, they belong to patients with many risk factors already, and some of them can be less than 1 millimeter in size. So you end up using 7/0, 8/0 sutures to make these anastomoses, and it can be it's a very precise procedure, and you have to have very steady hands, I have to say. There's 2 ways of doing it. You may have heard of pulmonary bypass machines. So one way is to stop the heart and attach the patient onto that. That in the cardiopulmonary bypass machine is a talk in itself, so I'm not going to go too much into the intricacies of it, but essentially it allows you to stop the heart and continue circulating blood around the body. With cabbages, there is a way of actually doing it without without going onto the pump, and this is something called off-pump cabbage. What's used instead is a stabilizing device called the octopus. I guess it looks like a tentacle from an octopus, possibly. That's why it's been named as such. But this essentially grabs onto, it sucks onto that part of the heart, and it will stabilize the heart in that part. So you put it in between the coronary that you're looking to anastomose, and it literally sucks onto it. And as the heart is beating, it doesn't keep it completely still. So this is why off-pump CABG is actually it requires a greater level of technical skill to do, because you're opening up the coronaries when blood is still flowing through them. So there are ways of moving that blood out of your field of view, but altogether it's a slightly more stressful type of procedure in that sense. But it avoids putting a patient on the pump. And there is research going on with regards to whether there is any added benefit. Ultimately, at the moment, though, it comes down to surgeons' preference. Some surgeons prefer doing it this way, some the other way. In some cases, it depends on the patient as well. So yeah, that pretty much sums up CABG in a nutshell, which is one of the key procedures that you do in cardiac surgery. So the next major thing that you come across is obviously the heart has four major valves, or four valves altogether actually, inside of it, which are essential to its function. So valvular disease is often treated by cardiac surgeons as well. Most commonly, the problems occur with valves on the left side, primarily because this is the side which is sort of higher pressure, and there's just greater pathologies that occur on that side. And a bicuspid aortic valve is obviously going to have a much greater effect than a slightly diseased pulmonary valve, because of the fact that it's being the heart's pumping blood at such high pressure through it to supply the rest of the body. So generally, right-sided valve abnormalities is limited to the tricuspid valve, and the pathogenesis often involves left-sided valve lesions, which then cause pulmonary hypertension, which then causes tricuspid regurgitation and right ventricular dilatation, etc. So it's very rare to actually get isolated right-sided valvular lesions. So just to kick things off before I go any further, I thought we'll just have a quick question on the types of valve replacement. So this is a scenario in which a 45-year-old gentleman presented with severe stenosis of his aortic valve. During the MDT, it is decided that valve replacement is required, given the mean gradient of 40 and the fact that he has severe exertional symptoms. Which type of valve replacement would be the most appropriate in this patient? The options are A, an Edwards-Perrimount valve, B, Edwards-Percival valve, C, a Medtronic 3-star valve, and D, a St. Jude's aortic valve. I don't expect people to really know the answer to this. I've intentionally put the names of the actual valves themselves rather than giving away anything more, which makes it even harder. But we'll be going through this after. Okay, so a real mix of responses here. It's like an equal mix essentially between Edwards, the Medtronic, and St. Jude's. I mean, ultimately, what I would say is that the patient will decide, and it's the patient's choice. But we as the clinician can present them with the positives and negatives and give our strong advice as to which one would be the preference. The key with this gentleman is that he's quite young. He's only 45 years old. So in that regard, in this instance, we would 100% advocate a mechanical valve replacement, of which there's only one over here. And that is D. So I purposely put it all like this and put two Edwards valves, and because if you knew there isn't too much of a difference between choosing either of those for a particular operation, but the key in this question was to get the mechanical valve out of these and know that a tissue valve would be less appropriate, unless of course the patient still decides to go for it anyway. It's their decision ultimately. So yeah, St. Jude's aortic valve. So talking a little bit about the types of valves and the reason why you would choose one over the other. So you can split them up into tissue, mechanical, and tissue valves can be either xenograft or homograft, mechanical, and then you can also have autografts. So that's sort of the broad way of splitting them. Tissue grafts, which the first three that I mentioned in the previous question, the Edwards Percival and the Edwards Magnet-Ease, they essentially, the main advantages of using those is that they obviously don't require warfarin or lifelong warfarin. However, and a lot of people don't know this and don't appreciate it, but they do wear out very much faster than a mechanical valve, especially in younger patients who are going to be a bit more active, less than 65 years of age. And often they can last, only 10 years. So in a 45-year-old, for example, that would mean being reoperated on, and the valve becoming, no longer functional in 10 years' time. At the age of 55, he needs another reoperation to have another valve fitted in. So that's the major disadvantage at the moment with tissue valves. However, some patients still just really don't want any inconvenience of warfarin therapy, or they get very scared by the potential side effects of bleeding and whatnot. They can also, so the difference between the freestyle and the other valves was that the freestyle is a stentless valve, and the only what I mean by that is that this is a picture of actually the Edwards Magnet-Ease valve. So what we mean by the stent is this. So the valve itself contains these leaflets and of a hair, and the stent allows the leaflets to be attached onto it. So all you have to do is stitch the outer ring of the valve onto, after you've removed the previous valve, stitch it onto the place where you want it to be. So it involves sort of one set of sutures and just parachuting the valve down onto where it's meant to be. The stentless valves, the Edwards freestyle one, essentially is a cylindrical shaped valve, so it doesn't contain this ring around it. And what that means is that it just fits better in a way, in how it should do. But however, the downside is that you have to do two sets of sutures, because you have to reattach the top part of the cylinder and the bottom part as well. So that can take a lot longer to do. So often the stented valves are opted for. The difference between the Percival and the Magnet-Ease one was that the Percival valve is an example of non or sutureless valve. And this is a technology that's been developed since the induction of TAVIs. And actually, even in open surgery, the Edwards Percival valve allows the surgeon to deploy this sutureless valve and saves a lot of time suturing. And again, there are studies being done to compare whether or not this is better than using a sutured aortic valve. Mechanical valves, on the other hand, last a lot longer, as I said, but they do require anticoagulation for life. This is a picture of the St. Jude valve. There is another valve that's been released called the Onyx valve, and that claims that you do not have to put patients on such high levels of warfarin, and or in terms of achieving INRs between 2 and 3, and says that you can manage with patients or manage their thrombogenic risk with INRs of less than 2. So that's obviously a major advantage. Lastly, autografts are grafts which essentially you're using the patient's own valve to replace the aortic valve. And the valve that's commonly used in something called the Ross procedure is your pulmonary valve. As I said, the pulmonary valve is less important than the aortic in terms of the fact that the pressures on the right side are a lot less. So using your own valve, it can be a great option for especially younger patients who are in their teens, who require an aortic valve replacement due to a congenital issue of some sort. And in fact, this has been shown that if you use their own pulmonary valve, then even remodeling occurs as they're growing up. to make it the most effective valve. And it's being the own valve, it lasts a lot longer as well. So essentially, as you can see from the picture, you take out the pulmonary valve from the pulmonary artery and put it, suture it top and bottom into the aortic roots. And then over here, you can see that you have to reattach the coronary cusps, or buttons as they're called, and anastomose them back onto the new graft. Because obviously when you take out the old part of the root of the aorta, you're going to have to take the coronary cusps out. I thought I'd drop in a picture of the cardiopulmonary bypass machine just to illustrate it a little bit better. So I did try and explain that a bit earlier, but obviously with valvular surgery, you have to put a patient onto a bypass if you're doing open valve surgery, whether it's through where you're cannulating them through the aorta and the veins on the heart, or peripherally in the femoral artery and veins. So as I said, in a nutshell, it's just keeping the patient alive and working as a set of heart and lungs for them. So blood is being pumped out of the cardiopulmonary bypass machine into the descending aorta, and the aorta is clamped. That's a clamp, clamping the rest of the heart, so that you've got passage for the blood with your mechanical heart, so to speak, in the machine, passing through the descending aorta. And then when you get venous return, it's also goes back in through the machine through the venous cannula, and there's various ways of cannulating the heart to achieve this. There's also, it's a very complicated structure, and there's a lot to it, in that obviously to stop the heart, there's something called cardioplegia that you use, and that essentially puts the heart into asystole to allow you to conduct the operation. And there's multiple reservoirs and heat exchanger to control the temperatures as well. But in a nutshell, that's essentially what it is. As I said, it's a very evolving specialty, and there's a lot that's gone on over the past decade, especially with regards to aortic valve replacements. With the intervention of the with TAVIs and transcatheter aortic valve replacements, there are a lot less or minimally invasive methods of doing the procedure. So traditionally, it would always be open heart surgery, whereby you do a stenotomy and open up the entire chest, and then stop the heart, make a cut in the aorta, and then do what you need to do with on the aorta and replace on the aortic valve and replace it. Now there are other methods, including a mini stenotomy and a smaller incision called the right anterior thoracotomy, to achieve the same thing. And these patients, you can, as I said, you can put them onto the cardiopulmonary bypass machine peripherally and allow yourself, for certain patients, to do this without essentially having to do a full stenotomy, which can improve recovery. Obviously, it's a lot more technically challenging doing it that way, but these methods are being developed, and a lot of surgeons are doing it very well. Then you have an entirely new form of minimally invasive surgery, essentially the transcatheter replacement of aortic valves. So this can be done a number of ways. You can do it transfemorally, which essentially, or you can do it even via the radial, which is what cardiologists or interventional cardiologists who do TAVIs do, transapically and transaortic too. So there's a lot of, well, there is a growing number of cardiac surgeons who are trying to learn these minimally invasive skills as well too. And as technology progresses, a transcatheter aortic valve could be a better solution, in the sense that, unlike other valves where you have to reopen and take it out and replace it once it's run out, these valves are cylindrical in shapes, and you deploy them and they open up. And then actually you don't even need to remove the old valve, the old aortic valve. It just it squashes it and opens up in place of it. And then the same thing can be done again if you need a replacement. You can just put another valve in and just open up in place of the old one that isn't working anymore. So it's quite an exciting time in terms of that. Moving on, talk a little bit about aortic dissection. This is because it's the main medical emergency that you come across in cardiac surgery. You've all probably you will have heard of the Stanford-DeBakey classification. So you have proximal and distal aortic dissection. So type A Stanford or DeBakey type 1 and 2 involve the proximal end of the aorta and require input from the cardiac surgeons. And it's a medical emergency. Every hour makes a huge difference in terms of the patient's outcome. Unfortunately, the way that these patients present can be quite misleading. Often they present to A&E with just chest pain or some neurological signs or just collapse and not much else going on. And typically, when assessed, A&E staff can go down a different path. And I've been recently doing a project on looking at the referrals that have been made to a tertiary centre, and often, they can be diagnosed from anything. Obviously, commonly with chest pain, you're going to diagnose ACS, but even something, sometimes they present with epigastric pain and are diagnosed with gastritis. And there was a case I saw that was discharged home, had to come back, and it can be very easily misdiagnosed, which is why you have to be very astute and able to pick up. So you have to be looking out for it. And there are a number of things that you can look for example, in chest x-ray, wide and mediastinum, difference in blood pressures between the right and left side. Just having in your radar with a patient who presents with some pain around the chest or neurological signs even with some pain, it has to be something that you want to exclude so you don't miss out this medical emergency. So essentially what happens is that you have, as you know, you have three layers in the aorta: the intima, the media, and the adventitia on the outside. So what happens is that you can sometimes get a tear, and that introduces a false lumen through which blood can keep filling, and at high pressures it just fills and fills and fills, and it creates this tear all the way down the aorta. So the key is finding out where this tear is and fixing it. And obviously, if any damage has been done, repairing that in the meantime. The CT scan shows you how, these false lumens can become very, very big very quickly, and are very high risk of rupturing and causing pretty instant death if that happens. So as I said, every minute matters. So what you want to do if you come across these patients is to stabilize them, give them adequate analgesia, control their blood pressure, and you do that by giving them inserting the central line, putting an art line in, monitoring their blood pressure, and starting them on labetalol or GTN infusions. And urinary catheter can also help monitor. So one of the things with aortic dissection is that it can affect a lot of the major body systems. So it can affect your renal arteries if it goes down to celiac artery and affects that and reduces perfusion to the kidneys. It can affect your bowels if it goes to the SMA, or if it can obviously cause neurological symptoms and affect the brain if it propagates or on into the brachiocephalic artery going upwards and carotids. So there's a lot of damage that can be done to very important systems throughout. So it's important to monitor and treat effectively. These cases, as I mentioned previously, can go on for a long time. Sometimes it can be very quick and brief, and the surgeon can sigh a breath of relief if that's the case. But often, because as I said earlier, sometimes they're often misdiagnosed as ACS. And what do you do if a patient's, you're suspecting them to have ACS? You load them up on aspirin, load them up on clopidogrel, all things that are going to make it a nightmare to control bleeding in patients who are bleeding actively, really, through this tear in the aorta. So hemostasis can be a big problem. So this is a case where I was fortunate enough to just watch from the anesthetic end. So you're getting sort of a really nice view. The aorta over here, you can see it's bulging and it's got a bit of bruising on top of it. And that's obviously the blood that's gone in that dissection that's formed. It's causing it to bulge and bruise. So what we've done is we've opened up the aorta here, and everything's happening very fast here. Every second matters. At this point, the patient's already on the bypass machine, the heart's stopped, and they're taking out the clots that formed, and it's essential to just find a point at which the tears occurred and see what the extent of damage is and repair it, essentially. So I'm going to just skip through this bit, actually. So there's a couple of ways of repairing it. Depending on the extent of injury, you can either do a hemi-arch replacement, which goes up to brachiocephalic and not beyond. Partial arch, where you also have to replace the brachiocephalic or the where it originates, and then a total arch as well. And then a hybrid procedure can sometimes be done involving vascular surgeons, which puts an additional stent down here called the frozen elephant trunk. I'm wary that time is passing and I want to get through a few other things. So we'll try and go through the next few bits as fast as possible. This is something I really wanted to teach you all about, because tamponade post-operatively is probably one of the most critical and complications that can occur post any cardiac surgery. So you might well be someone as a junior covering cardiac wards, even if you're not in specifically on a rotation on it, but you might be covering surgical wards, including that, and be asked to assess a patient. So this is something that you need to have in the back of your mind. And essentially, it's the rapid compression of the heart by the accumulation of fluid, often blood, within the pericardial sac that reduces ventricular filling and cardiac output. And by definition, it's a surgical emergency. Early recognition and management is absolutely crucial. Typically, you will have read about the signs to look out for being Beck's triad, where you have muffled heart sounds, drop in blood pressure, reduced cardiac output, and increased right-sided pressures, resulting in raised JVP or whatever. But essentially, these things can be very easily masked in cases of tamponade post-operatively, because these patients are often on so many other things, like, for example, they might be hypovolemic, they might be beta blocked, they might have poor LV function to start off with, and it's not always clear that it's tamponade. But if the patient's deteriorating, you have to suspect and have a high index of suspicion, and you can investigate it further by doing a transthoracic echo. But again, in the post-operative period, this isn't always very clear, because you've got or conclusive, because you've got drains which have been inserted, and that can obscure the view. So usually transesophageal echo is better, but ultimately it's a clinical diagnosis, and that's what you have to go for, and diagnose it quickly. And if it is diagnosed or suspected, the only intervention is surgical. You have to reopen the chest in this instance. If there is evidence of cardiac tamponade in other patients, sometimes you can just do a pericardiocentesis, but in these patients, you have to restenotomy. For example, it might be due to, you might have the buildup due to a bleed in a vessel. So you have to control what the cause of the tamponade is as well. This is something that I want to talk about as well. So sometimes the first presentation of a tamponade would be that the patient goes into arrest. Now, in any other setting, you would immediately initiate the ALS algorithm when patient goes into arrest, but this isn't any other setting. Post-cardiac surgery, we have a modified algorithm, which is called the CALS algorithm, or cardiac ALS algorithm. The primary difference is that is essentially the not so insignificant inclusion of the restenotomy that you can see down here as part of the algorithm. So that's where you end up to, and you end up at that point sooner rather than later, because often if they reach that point, they do need a restenotomy. So if they're in VF and they've still got some sort of rhythm, then you do shock them. Again, this is slightly different from the ALS algorithm. You shock them 3 times, one after the other. You don't wait 2 minutes in between, but you do that. You give them amiodarone, and then you just have to reopen so you keep shocking them every 2 minutes after the first 3 until you're ready for the restenotomy. Otherwise, if the pacing isn't doing it, then you have to get ready for restenotomy. So there's many Carl's courses run across the country, and I actually went to one in Papworth. It was a lot of fun, very informative. It didn't drag on as much as the ALS courses do. And I mean, they ran a full simulation at the end, including a restenotomy on a model. And that also included a scoop and run, essentially, where the patient's arrested and you have to not only do the restenotomy, but you transfer the patient into theatre. And it was all very exciting, and it was all filmed, and we got to watch over it, and we managed to achieve the record time of around 6 minutes and something to fully open the chest up and apply the shock from the moment of presentation. But I would highly recommend that, and to do one of those courses, especially if you might potentially be looking after these patients. In terms of the setup, very briefly, the differences are that you have your stenotomy cart ready over here, and you also have someone who's going to do the restenotomy over here, and an assistant to help out with that as well. Otherwise, you've got similar roles: someone for airway and breathing medicine, a team leader, and someone for defibrillation and pacing. Finishing up on cardiac surgery, some honorable mentions. It's impossible to cover everything in such a short space of time. There are so many branches of cardiac surgery, and some of the more niche branches that you can go into are congenital surgery, transplant surgery. Both of these are a lot more. It's like congenital surgery, you're as if adult cardiac surgery isn't hard enough. You're operating on hearts the size of, a fist, if not smaller, and it can be very, very delicate. And but it's also immensely rewarding, obviously, to give such a young patient new lease in life. Transplant surgeries, again, these are patients who have absolutely no other option left, and you're essentially giving them a new lease in life. There's a lot of developments going on in terms of mechanical support as well for these patients who have no other option left, who are awaiting transplants. And one of those things is a LVAD device, or left ventricular assist device, to help the heart function in that period before they have a donor ready for transplant. Right, so I will talk briefly about some key thoracic pathologies as well. Thoracic surgery, I worked at the Brompton, and it is also in itself a really beautiful specialty, and I really enjoyed it. It's very different in some ways to cardiac surgery, but you can also sometimes have to fiddle with the heart too. So having those skills are very important as well, in terms of being wary of the heart. And in some ways, they're even braver than cardiac surgeons, in that there's not an immediate cardiopulmonary bypass machine available, but they're still dealing in that same area with all those major vessels coming out. So I will briefly touch on some of these, the key pathologies. A lot of thoracic surgery involves cancer. So we'll just kick things off with that. Another question, just to keep you all engaged again, if the last bit was a bit prolonged. So what is the most common type of lung cancer that we have? Option A is adenocarcinoma. Option B is small cell lung cancer. C, squamous cell carcinoma. D, large cell carcinoma. And E, carcinoid tumor. Okay, so the majority of people got that right, actually, in adenocarcinoma. Close second was squamous cell carcinoma, which is also relatively common, but not quite as common as adenocarcinoma. So adenocarcinomas take up approximately just over a third of all lung cancers. And in terms of the ones that we treat in surgery, often are the large majority, because these cancers are often peripheral, so easier to dissect out if needs be, and can present earlier. They're not as aggressive as small cell lung cancer, for example. There's an increasing number of adenocarcinomas which are, whilst they're associated with smoking, there's an increasing number that occur with non-smokers as well. And typically the population is young Asian females. Small cell lung cancers are very aggressive cancers. Usually there is not really any role for surgery in them. And squamous cell, again, strongly associated with smoking. These are often more centrally located and can obstruct airways, which result in slightly more tricky procedures at times. And carcinoid tumors, whilst they're not as common in occurrence as the others, they're still, because of their slow growing nature in typical carcinoid tumors, they can essentially be cured by surgery. Yeah. So as I mentioned, there's a rising incidence in adenocarcinomas in particular. Most surgery is performed on, so what you normally do with lung cancer is that you stage the cancer, and staging is extremely important. And knowing the anatomy of the lungs, anatomy of the lymph nodes around the lungs is vital to that. And earlier stage cancers in general can be not always, they can be resected and with RO resections through surgery and have a much more reduced rate of recurrence, although there is still a significant rate of recurrence with these cancers as well. But those with early stage cancers, you can perform curative surgery for them. There is a lot of research going on in thoracic surgery in terms of more sort of hard data on recurrence in those who've been operated on, and also what's the rate of recurrences in, and whether there's any benefit in performing surgery in later stage cancers which have reached stage 3 or stage 4, for example. There is also research being done to investigate procedures or investigations which will help detect cancers at an earlier stage, and therefore diagnose them at an earlier stage and make them more amenable to surgery and cured. So with these cases, an MDT approach is taken with oncologists, radiologists and whatnot, always, and a decision is made as a team as to whether surgery would be appropriate, and then ultimately it is the patient's decision. Investigations done include a high resolution CT, which have again evolved dramatically, so that part of the reason why there's an increased incidence is it must be in no small part because they're incidentally found so much more often with high resolution CTs. PET CT scan will help find out whether or not it's more likely to be malignant in nature. And you also have bronchoscopies which can be done to help help sample, for example, some through EBUS, for example, some lymph nodes, or if there's any invasion in the airways to help investigate that further. But essentially you stage them and come up with a plan. In terms of the surgical approach, there's different ways, different approaches that are taken, and going from small to big, you can either take a wedge resection, which is a small part of a lobe, a segment which, if you know the anatomy, each lobe consists of 4 to 5 segments, and you can take out a group of those segments which are supplied by bronchioles and have their own blood supply, and that can help preserve more lung. Most commonly for an adenocarcinoma that's detected, a lobectomy is done, and if there is no other way to avoid it, a pneumonectomy can be done. Wedge resections are usually more often done for diagnostic purposes, although there is research being done as to whether or not sometimes it can be curative with an RO resection as well. But right now, segmentectomy or lobectomy would be more sort of gold standard. Sometimes what you do also is you do a wedge resection, and you send that off intraoperatively to be seen as a frozen section and by the pathologist, and then they can advise further as to whether this is a cancer and you should proceed to do a lobectomy, or whether it isn't, and you can just leave the patient as it is. So traditionally, all lung surgery was done open via thoracotomies, and you will have all heard of the posterolateral scar to look out for. But nowadays, more and more surgery is being done via bats, and this is something that's becoming more and more common. As you can see, it just causes patient, again, great for cosmetic reasons, causes minimal trauma as well as compared to this huge cut you have to make. And as you know, there are intercostal, lots of nerves passing beneath the chest wall. So with such a large supply of, or large network of nerves, pain is a big issue post-operatively. So if you do a big incision like this and you're retracting the ribs across, that's going to cause a lot of problems pain-wise after the operation compared to this. And these days, there's even single port or uniportal VATS procedures being done. And that's what we're doing often at the Brompton in the first instance, where you do everything through just one port. This is like an image of what it kind of looks like when you look through the camera into the chest and you're trying to resect a lobe out, essentially. What you're trying to do in this surgery is to dissect out the vessels and the main structures supplying that lobe. So each lobe will have a bronchus, an airway, a vein, and an artery supplying it. And it's always a puzzle. Each patient is unique in their own way, and you have to try and figure out which one is where the artery is, where the vein is, and where the airway is, and just isolate them and dissect them out and cut them, resect them, without ideally causing damage and a massive bleed, which causes a lot of panic, especially because they're really fragile, as you can imagine. The pulmonary artery compared to the aorta is a lot thinner because it's a low pressure system. So any sharp movement against it can cause a small tear, and when that happens, it's just going to become a flood of blood, and you won't be able to see anything. And they can lose a lot of blood very quickly. So that can be quite a scary thing in those procedures. Oh, so moving on to the next part. I would, if this was a more completely interactive talk and you're in front of me, ask you to make a spot diagnosis there. But for those of you who spotted it, well done. There's a tension pneumothorax building up over here on the left side. And pneumothorax is one of the other really common things that, as a thoracic surgeon, you have to deal with, and you'll have to deal with as a junior doctor too. So I thought it'd be useful to mention that here. What I mean by primary spontaneous, secondary spontaneous is the method in which the pneumothorax occurred. So primary pneumothoraces occur in that typical demographic of a tall young male smoker. And secondary spontaneous is usually secondary to some underlying condition. So whether that be malignancy, infection, COPD, or whatever it may be. I thought it would be really useful for all of you to learn, for me to teach you a little bit about chest drains themselves. Obviously, the treatment of tension pneumothorax is emergency chest drain insertion in that safe triangle, and follow your ATS guidelines for that. Once that's done, actually, when you're on the ward and looking after a patient with a drain, I found as well when I was very junior, even in general surgical ward, I wasn't really very clear to me how a drain works and what to be looking out for. So I thought I'd just have a slide about what you should be looking out for. So there are different types of drains, but commonly used ones are ones with an underwater seal, and often a lot of places use something called a rocket drain, where you've got the patient pipe coming down here, and then it's sealed underwater at the other end, and then you have another path of the hair to introduce suction, to actively have suction of fluid if you need from the lung. The important things to note here is that the underwater seal must remain intact at all times. Therefore, you have to have the chest drain up in an upright position, and air can re-enter the pleural cavity if the tip of the tube is above the surface level of the water. So this is stopping it from air going from the end of the tube back into the patient's lung. So you have to maintain that seal for that reason. That's what we mean by a seal. The chest drain must always be kept below the level of the patient's chest as well. And the reason for that is you're using gravity to help make sure that things are flowing the right way, which is into the drain, not the other way from the drain into the patient's chest, which wouldn't be good. So there's some terms that are used called swinging and bubbling, which don't always make sense if you don't know what they mean, especially when you're starting out and you just come across a chest drain. All we mean by swinging is this is the movement that occurs over here when a patient's breathing in and out. And if they're not swinging, then it cannot mean that the patient's drain is blocked, in which case you want to try and unblock it. When the patient breathes in, obviously the pressure is reduced inside the thorax, and that's going to cause the fluid level to go up. When the patient breathes out, the pressure is increased, and it's going to cause the fluid level to go down. So that's your swinging. What do we mean by bubbling? If a patient has an air leak, and an air leak, by the way, is just a leak of air from a deficit in the lung, a tear or some sort of weakness, a bulla or something. It's leaking air actively from the lung when the patient breathes in, and that's obviously and that's what essentially causes a tension pneumothorax if you don't create a passage for that air to be safely taken out from it. So if they've got bubbling, all we mean is that if a patient's taking a deep breath in, or if they cough, there's bubbles is essentially emerging over here, and that means that they've got active leak of air which needs to be healed before you take the drain out. So don't take the drain out whilst they're still bubbling. If the tubing becomes disconnected, you should basically just clamp the tube right next to the patient as close to the chest as possible immediately to stop anything going in, and obviously reattach the system and unclamp as soon as you can, and then do a chest x-ray to make sure that there isn't anything else going on after all that commotion. And the other thing to bear in mind is that pain management in these patients is critical. Having this tube in that area of behind the chest where, as I mentioned, there's so many nerves, is not the most comfortable thing, and these patients, often important for them to be mobilizing. So it's important to manage their pain with Oromorph or whatever else is needed, not just simple paracetamol if that's not sufficient. So this patient comes in with a pneumothorax, and normally you deal with that in a medical way. There are some instances where you have to refer to surgeons to treat it further. And over here, I was just going to talk a little bit about what the BTS guidelines state for the reason for referral. And you may, as an F2, for example, have to refer some of these to the local thoracic center, or if you're on a thoracic placement, have to accept this. So essentially, if there's a second, if this is a case of a second pneumothorax on the same side, that's a reason to refer to thoracic surgery. If it's the first one, but on the contralateral side, also requires referral. If it's a bilateral pneumothorax, if there's a persistent air leak, which is prolonged beyond 5 days, if there is a spontaneous pneumothorax, and for certain professions such as pilots and divers, and if the patient's pregnant, all of these things require further intervention from the thoracic surgeons. So what do the thoracic surgeons do when this patient arrives to them? How can we perform surgery to help them? As I mentioned, sometimes these patients will have a reason for why they're constantly a pneumothorax is occurring. They may be high risk because they're COPD, or there may be some other cause such as bulla. So usually these procedures are always performed VATS. And what you want to do is get rid of any underlying causes of an air leak, for example, a bulla, by resecting out that part of the lung with a stapler. And then there's two methods that are primarily used to essentially stick the visceral surface of the lung onto the chest wall. And as you can imagine, the parietal and visceral pleura have this potential space between them. So if you obliterate that, then there's nothing that can fill in between and cause the lung to collapse again. So the key ways of doing that are talc pleurodesis, which uses talcum powder, a surgical type, which doesn't have anything in that will cause nasty things, and pleurectomy too. So usually we opt for talc pleurodesis if the patient's lung is able to re-expand. If the lung is not able to re-expand, then a pleurectomy can be indicated better. They both do the same thing in that they allow that potential space to be obliterated by attaching the surface of the lung onto the chest wall. And so compared to cardiac surgery, in thoracic surgery, these are slightly more simple procedures, so to speak. They don't last as long. You can do a pleurectomy or talc pleurodesis within an hour, probably even half an hour talc pleurodesis easily from start to finish, having done all the other things that you need to do. So there is a bit more sort of variety in terms of the length of cases. They're not all super complicated. Again, a patient might present with empyema, and that's essentially a collection of pus in the lung, which antibiotics cannot touch, and they're getting worse and worse and worse on medical treatment, and they require the thoracic surgeons to clear it out, because it's usually what happens is that it becomes contained in locules, and the only way to get rid of that trapped pus is to take down these locules of pus and essentially wash it all out. A drain won't cut it. So that's what we do, and it can be actually a really therapeutic and pleasing procedure to just separate the lung out and just go around and just find these little pockets of pus and just get rid of them. I guess it's the thoracic surgery equivalent of an abscess drainage. And in severe cases, if that isn't sufficient and the lung isn't able to re-expand after that because of lots of damage to the visceral pleura, something called decortication may have to be undertaken at a later date, which is a procedure I can say from experience, having seen it, is something you want to avoid at all costs, because the visceral pleura is like peeling like orange peel off the top of the lung, and it has so many potential things that can go wrong afterwards in terms of air leak and recovery afterwards, that you really do want to avoid it unless it's an absolute last resort. Again, with thoracic surgery, some honorable mentions. There is a lot more a lot of complicated procedures that are done, and joint things that can be done with other specialties in terms of reconstructing parts of the thorax. One thing I forgot to mention, by the way, in cancer surgery is that mediastinal tumors are also operated on by thoracic surgeons. So a thymoma is operated on by a thoracic surgeon. And sometimes these can infiltrate part of the ribs and sternum or something, and you have to obviously resect that area out as well. And therefore there is the opportunity to subspecialize into chest reconstruction surgery, or likewise, if there's invasion of or stenosis of the trachea, you may have to resect out the trachea entirely or part of it, and this is another sort of mode of surgery in thoracics. The last thing, as I mentioned before, is that you do sometimes have to do a bit of cardiac surgery within thoracic surgery, and I just a few months ago experienced that in a very difficult case that we did, removing a thymoma. Now, I drew out this illustration afterwards as well, just because I was so it was the first time I'd seen anything like it, and I thought it was really cool to see. And it shows how, as I said, you have to have that courage as a thoracic surgeon in some ways even more. So this tumor had invaded the innominate vein, which is one of the veins that runs just above the aorta up here. This is a question you'll be asked by all cardiac surgeons, by the way, if you go into one of the theatres, so just know that it's there. And then obviously you have the left innominate vein there and the right one there, and they join onto the SVC, which normally runs down here. But this tumor was invading the left innominate and potentially part of the SVC. So what we ended up doing to allow venous return of that upper part of the body is cutting out the part of the innominate that was being invaded, cutting out the part of the SVC that was being invaded, stapling stapling it across, and then forming a graft between the innominate vein directly into the atrium. All of this on a moving heart without any cardiopulmonary bypass. So it was pretty cool to see, and a lot of physiology involved in that as well. As you can imagine, not having the rest of your SVC going into the right atrium, there's going to be symptoms of SVCO afterwards. But yeah, there are lots of interesting cases in thoracic surgery too, and it's a great specialty, whichever one you branch out into. I'm wary that time is short, so but I really wanted to let you know a little bit about how to get involved a bit further and what the training pathway is like. So briefly regarding this, the training pathway itself, if you're interested in applying, there's applications both at ST1 level and at ST3 level. ST1 level, you can start applying straight after F1. Straight after F1, you apply during F2. And then essentially you're able to apply for ST1 level up to 3 years after your completion of foundation year training. And you cannot exceed 18 months of surgical experience post F2. There is another way of entering it if you're in the middle of core training, and you can enter it via ST3 as well. Generally, they're trying to create more and more run-through posts and ST1 posts, and there've been fewer ST3 posts the past couple of years. And the training in total, once you're in, is 7 years in total. Obviously, if you get in via ST1, you don't have to go through the whole process of reapplying as a registrar, and you go on straight through. And you have mixed cardiothoracic training in the first 3 years, and then you have to sort of choose between the two. The next 4 years, essentially, you're specializing in your chosen side. But I'm sure there's ways to go between the two if you do change your mind later on. The other thing to note is that over here at this point, after the first 2 years, there's also the option to go into some of those subspecialties, which I mentioned, congenital and transplant. But that's the training pathway in a nutshell. I would highly recommend, if you're interested in reading up a bit more about the experiences that occur within the specialty. There's a lot of novel books out there written by cardiac surgeons from this country, which I've read and really thoroughly enjoyed and found very inspiring. Stephen Westerby's got 2 books out there, Knife's Edge and Fragile Lives. Very entertaining reads, regardless of whether you ultimately want to go into cardiothoracic surgery or not. And Muhammad A Ashraf, also an incredible individual, published the Angina Monologues, which goes through a lot of interesting cases as well. So those can be quite good to read. The other things you can do, the SETS is the National Society for Cardiothoracic Surgery in the UK. Get involved with them. They have an annual conference every year, which has unfortunately been hindered due to the current COVID status. But they've always got things for students and potentially aspiring cardiothoracic surgeons. So get involved, sign up to them, and I'm sure you'll be notified of any relevant events for you. And I would thoroughly recommend, at the very least, just going to a cardiothoracic unit and just going into theatre and seeing if you like it or not. I didn't really do that during my medical school, and I only got the opportunity, it was after my F2 actually. So had I gone a bit sooner, I probably would have discovered it sooner and just found out I loved it so much sooner. Had I not gone at all, I would never have known. I would never be where I am now. So I would highly recommend you just go to visit your local centre. There's lots of places abroad as well. This is a picture of the Cleveland Clinic, but there's lots of medical electives you can go on in cardiothoracic centres as well, which are interesting. And lastly, I would say that try and find someone, whether it be in this specialty or somewhere else, someone who helps inspire you, someone who helps take you under their wing a bit and really sort of engage you in that specialty. And for me personally, this photo obviously shows me on the right, and Mr. Begg was the one who I first came across. He's an incredible surgeon working at St. Thomas's at the moment. cardiac surgeon. And I came across him because one of my friends was working in the cardiac department there. And that moment changed my life forever, really, because I got chatting to him. And at that time, I was looking to explore various specialties and got into a cardiac surgery theatre. And he was inspirational. And he's been really, really influential since then in terms of me taking the path that I have. And all the other consultants were great there too. And I was working at the Brompton, Professor Lim and Mr. Budari, also great surgeons. And I know the guys, I've whilst not worked in the other centres, I know there's great individuals all throughout. So find someone and show passion and enthusiasm, and there's no reason why they won't. That will encourage them to give you more and you to get more out of them. So that's all I wanted to say to help to just conclude this talk, and I hope you've enjoyed it. I know we've possibly overrun a bit, but I'm happy to take any questions. Starting to lose my voice.
Thank you so much, Muhammad. That's a really, really comprehensive talk, and I think you covered a lot of stuff today. We have a couple of questions first. So the first one was kind of about, I don't know if Baker's here actually.
Sorry?
Is Mr. Baker?
Yes, thanks.
Oh, hi. So this first question is, I think it'd probably be better answered by a consultant. So I was recently speaking to a neurosurgery reg who expressed a concern about the number of consultant jobs available in the UK. I was wondering if there was such an issue with cardiothoracics.
So I think, thank you for allowing me to join this session. This is a cyclical thing. So when I was a medical student over 20 years ago, there were articles in the national press. There was a article in the Times saying 500 gynecology trainees with no consultant job. That was a headline. So 500. So there was a crisis in terms of workforces. So there was a time where they trained so many gynecologists and obstetricians, and there was no consultant jobs for them to go to. And about 10 years later, the same thing happened to cardiothoracic surgery. So when I was at a very junior stage, suddenly they were saying there'll be no jobs and there was going to be no consultant jobs. So these are all sort of projections. And so at the moment, what's happened is, and it's happened maybe in neurosurgery and other surgery specialties, ENT, I know, and cardiothoracics, that there are a lot of trainees coming through the system. And every year, because it's a small specialty, and unlike some other specialties which may be expanding numbers, there has been some expansion. Thoracic surgery has increased by several fold over the last decade because of more lung cancer operations. So that may be perception that there is lack of consultant jobs, but if you look at all of the trainees, even from 15 years ago, many of them ended up still in the job or looking for opportunities elsewhere. So I don't think that should be necessarily something to focus on, because it's very dynamic. And workforce planning, if people want to look at it more detailed, they should go to the workforce report in the SCTS website. There's a workforce report, and it's talked about these very things in terms of adult cardiac surgery, thoracic and congenital. And actually in some areas there's going to be perceived demand. For instance, as transplantation increases and there's going to be more donors due to the opt-in rule and mechanical circulatory support. So there are some areas where they're going to definitely need more surgeons, and in thoracic surgery. So consultant jobs are very competitive, and that whenever a consultant job comes, for instance, there'll be up to 30 applicants for one job. And so what that enforces, and it's like everything, is very competitive. You have to ensure that you, not just when you get your training number, you carry on building your portfolio clinically, academically, and then additional fellowships. So I think that the message is out there. That's why a lot of people think that there aren't many jobs in cardiac surgery. It's a dying specialty because of some of these early perceptions. So choosing to go into a specialty or not should be based on a positive, rather than, you don't want to do it for this reason. And the people who, consultant jobs as one of those things where, unlike when you apply for a training number, they're very unpredictable. There's very dynamic situations. And so it's just, the key is to get as well trained as you can. And there are many opportunities, whether in the UK or abroad and so forth. So I think it's better to dispel those things. They are issues and they are concerns, but I think at this early stage, it's hard to predict what will happen in 8 to 10 years time. And if anything, there is still going to be ongoing demand for cardiac and thoracic surgeons. As the population gets older, newer modalities of treatment occur as well.
Okay, thank you so much. That's really, really great answer. We have another question from Muhammad. So what can a third or fourth year medical student do at this point to maximize their chances of getting into cardiothoracic, so ST1 or 3?
I think you should ask, one of your moderators, Laura, was a fourth year medical student when she came to our theatres. And so medical students, whenever I see a medical student, the very few medical schools have specific firms in cardiac or thoracic surgery, but it's often allied to have a special. So I encourage them firstly to come to wards, and even when they come to theatre, firstly just to observe how things work in theatre, the teamwork, the elegance of the surgery, the physiology, and then those who are even keener, we encourage them to come and scrub in. So first of getting even closer to the action, and then even more than that, once if you're even keener, we're happy to teach, and the teaching happens by virtue of some of our surgical assistants who are very skilled nurses who are trained in parts of the operation, and students have come and they're allowed to actually partake, even and some of the most amazing, when students do that, you can see the glow when they get to even close even a centimeter of skin or take an inch of vein, and then even when they get to touch the heart for the first time. So all of these experiences are transformative. Whatever branch of surgery you want to do, when you're a very early stage medical student or you're a trainee, you've got an idea of what the specialty is, but it's only when you immerse yourself in it and when you actually do the surgery, it's in the act. Surgery is not like physicians, it's actually the act of surgery that gives you a unique satisfaction, a unique joy, a unique pleasure. And that's why I think, come to theatre, come and take part. And so what you can do is get involved clinically, get involved in any academic work, get involved in surgical societies, and all of those things, will be useful in earning points towards your ST1 application.
Okay, thank you. We have quite
quickly, what I would add to that is for anyone out there who's looking to apply, there is a shortlisting criteria that's available both for ST1 and ST3 level, and that's on the Wessex Deanery website, I believe, or otherwise you can just make an account on Oriel and just get hold of it that way. That's essentially a matrix, and if you download that, print out, and just figure out what you have, what you don't have, and then essentially you can work your way towards maximizing your points and therefore your chances of getting into cardiothoracics.
I'd just like to add one further thing to that. First of all, thank you very much, Mr. Bake, for joining us. It's always a great honour to have you with us. And I would say to anyone that is looking at building their portfolio and working towards getting these points, especially as a medical student, if you go to theatre and as Mr. Babe was saying, even closing that 1 centimetre of skin, I can't take the grin off my face thinking of it. It's just such a great feeling. And even just thinking of those little triumphs in life, that will give you the motivation to go away and do the additional work and academic projects and things when you think that's really what I want to do every day. And you need those times to give you the motivation to then go away and actually put the work in elsewhere.
Thank you.
Yeah, so I think we're actually kind of running out of time. So we have, if it's possible, if you're happy to answer these on the Facebook or something, the Facebook event, we'll put the questions on there, or by email, if you're happy to show your email, that'd be really great.
I think my email was on the slide at the end that I had put up, but I don't know if anyone managed to note it down, but I'm more than happy to take any emails.
Would you mind putting it in the chat or something?
Yeah, I'll put my email here.
Thank you so much. Just a lot of people have questions about just general questions.
Yeah.
Yeah. So thank you so much. It's a really, really great webinar.